This is a case of severe epistaxis treated through endovascular embolization of the sphenopalatine artery. The patient is a 68-year-old who presents with uncontrolled epistaxis despite multiple cauterization attempts. Had previously undergone nasal septoplasty and turbinectomy and ethmoidectomy for deviated septum 2 days prior. Injection of the external carotid artery reveals normal anatomy without any obvious evidence for extravasation, which is the norm in these cases. An 017 microcatheter over an 014 wire is advanced into the sphenopalatine through the internal maxillary artery, which is located right at that angle where we are with the wire right now. We deliver the microcatheter over the previously placed wire across the loop into the sphenopalatine. Should be noted there are some key branches at this location which should be considered. There's the inferior orbital artery, as is noted in this lateral view. There's the greater palatine artery, which heads inferiorly towards the turbinates, and then there's the sphenopalatine, which is best seen on the AP dimension. You can see the wire is being held in place while the microcatheter is advanced into the sphenopalatine. An angiogram reveals that we are in the palatine segment of the vessel. The microinjection showing vascularity in the region of prior operation. Again, the goal here is not distal embolization with occlusion of the microvasculature, instead a proximal embolization to reduce the pressure head. The microcatheter is now prepared with injection of DMSO, and then onyx is being advanced forward through the microcatheter, again with the goal to cause a primary block in the sphenopalatine. There you just note that the sphenopalatine is being occluded. There's a little bit of flow into the greater palatine and towards the infraorbital. So this is a proximal plug created in the sphenopalatine. When you do an injection, you can see the infraorbital and the palatine vessels are open, but the sphenopalatine is proximally occluded. There's great collateralization in the external carotid artery, and therefore there is no real concern for ischemia. The catheter is withdrawn.